Well, first of all, I'd like to thank Pierre Clavian, the President of the Congress, for the invitation to give this talk. This Congress has been a marvelous example of Pierre's ability to carry out important administrative functions flawlessly. So thank you, Pierre, for this opportunity. I'd also like to thank my good friend and colleague Keith Lillimo for that very generous introduction. I'd like to title my talk, Pancreatic Surgery from Halsted to the Present. This is the last portrait of William Stewart Halsted. He's the most important, influential, and innovative surgeon that the United States has produced. When the Hopkins Hospital opened in 1889, he was the first chief of surgery. He's well known for a variety of contributions. He started residency training in surgery in the United States. He, along with Bassini, developed the first operations that were successful for curing inguinal hernia. His Halsted radical mastectomy was the operation of choice for decades for women with far advanced breast cancer. He was the first surgeon to use a plate and buried screws for long bone fractures. He and his good friend Coker made many contributions to thyroid and parathyroid surgery. Perhaps less known is the fact that he was the first surgeon to successfully resect a periampullary cancer. In 1898, he explored a 58-year-old woman who was jaundiced, who he thought had a common bile duct stone. But at the time of surgery, she was found to have an ampullary cancer. So he resected the second portion of the duodenum and the ampullary cancer, the end of the bile duct and the end of the pancreatic duct, and did an end-to-end anastomosis between the first and third portions of the duodenum, reimplanted the bile duct, and reimplanted the pancreatic duct, an operation that I think is probably more difficult than the current pancreaticoduodenectomy. The patient survived, but remained jaundiced, probably because the hepaticoduodenostomy had strictured. So he re-explored her and swung the gallbladder down to the third portion of the duodenum. The jaundice cleared, and the patient was discharged and lived until she eventually died of recurrent cancer. That's the first successful resection of a periampullary cancer. Now, the same year, Cordovilla from Italy, a surgeon I think well known to this audience, performed a similar but perhaps more extensive operation, but the patient unfortunately died about 3 weeks after surgery. The first successful pancreaticoduodenectomy was performed by the German surgeon from Berlin, Kausch. He performed the operation in 1909, and when the patient survived, he reported it in 1912. It was for an ampullary cancer, and it was done in 2 stages. Now, exactly 20 years ago, in 98, Andrew Warshaw, who's pictured here on the right, a well-known pancreatic surgeon to this audience, and I were at a meeting of the German Surgical Association, and we decided to pay homage to Kausch as the originator of the operation that we both were fond of and performed on many occasions. So we went to the hospital in Berlin, where Kausch performed the first pancreaticoduodenectomy, the August Victoria Krankenhaus, and both kneeled and paid homage to the individual who developed the operation that we became so fond of. Now, the operation was popularized by Whipple and his colleagues in 1935 when they presented 3 patients to the American Surgical Association, all operated upon in 2 stages, all for ampullary cancers, and 2 of the 3 patients survived. This is the illustration that appeared in the Annals of Surgery. The first stage, the anastomose, the gallbladder, and the jejunum to the stomach to decompress the biliary tree, and then at the second stage performed an operation not unlike Halsted's by resecting just the second portion of the duodenum. Now, I. Ridgway Trimble, another Hopkins surgeon, reported the first 1-stage pancreaticoduodenectomy in 1941, again for an ampullary tumor. This is the illustration that appeared in SGNO by Max Bradel, the first medical illustrator in the United States, who was actually from Leipzig. Now, the operation obviously evolved until in the 40s, 50s, and 60s, when one talked about a pancreaticoduodenectomy. One was referring to removing half of the stomach, all of the duodenum, the proximal jejunum, the neck, head, and uncinate process of the pancreas, and the gallbladder and distal biliary tree. And even though there are many ways to reconstruct such a patient, an end-to-end or end-to-side pancreaticojejunostomy, an end-to-side hepaticojejunostomy, and a gastrojejunostomy became the standardized procedure. Subsequently, besides the classic Whipple, pylorus preservation was introduced, and now both procedures are used frequently. Now, in the 60s and 70s, when the operation had become standardized, as our prior speaker mentioned, the hospital mortality was 25% in those institutions that were willing to report their results. The outstanding institutions like the Leahy Clinic, Mass General, the Mayo Clinic, etc. And the 5-year survival was 0 in most series and 5% in the best. Now that began to change. From 1969 to 1980, this is the Johns Hopkins Hospital experience with just the 4 periampullary cancers: head of the pancreas, distal bile duct, duodenum, and ampulla. From 1969 to 1980 at Hopkins, a 10 or 12-year period, we only did 17 pancreaticoduodenectomies. We lost a ton of blood. I don't remember it, but there it is, 3,200 milliliters. We needed to give a lot of blood. It took a long time, and we were not immune to the high mortality that the other institutions throughout the country who were reporting it. It was 24%. In the early 1980s, we started doing a few more. We lost a little less blood. We still had to transfuse patients. It still took a long time to do it, but the mortality started to drop. Now, I became a chair at Hopkins in the middle 80s, and we became interested in this operation and subsequently have done a lot of pancreaticoduodenectomies for the 4 periampullary cancers. About half of them classic, half of them pylorus preserving, 500 ml blood loss. The median number of transfusions now is 0. It still took us a long time to do it, but the mortality dropped down to 1%. Now, why is that? Well, volume was an important factor. You can see these are the pancreaticoduodenectomies done for all indications at Hopkins. In the 60s and 70s and early 80s, we only did about 10 a year. For the last 25 years, we've done at least 100, and for the last 5 or 6 years, we've done between 300 and 350 a year. And we've learned the anatomy better. We can anticipate complications, intervene earlier. So volume has made, obviously, a big difference. Perhaps the biggest difference, however, is we've learned how to drain the pancreaticojejunostomy. Leakage from this anastomosis with abscess, sepsis, bleeding, and death was the reason for the 25% mortality. And back in the 70s and early 80s, Penrose, cigar drains, a variety of drains were used. We now use closed suction silastic drains, and we put drains directly on top of and underneath the anastomosis. Now, all of us learned during our training, you don't put drains right on an anastomosis because it's going to promote leakage. But for pancreaticojejunostomies, the important thing is not whether or not it leaks, it's whether or not it's adequately drained. So if you drain them in this fashion, it doesn't matter whether you do inversion, invagination, duct to mucosa, with or without a stent. The important thing is to drain it adequately. It may increase the incidence of your fistula rate, but they'll be controlled and it won't result in sepsis and death. Now, who to do the operation on? This patient is 103 years old. Now, some have said she looks in better shape actually than her surgeon. When she came to me, I thought there has to be an age in which you're too old to have a Whipple, and it probably should be 100. But then her daughter, her granddaughter, and her great-granddaughter came to see me and said, no, she's very active. We want you to operate on her. So we did operate on her. She did fine, and she was from West Virginia. They're tough people in West Virginia. She would never come back to see me post-operatively, but I heard that she died 3 or 4 years later. I assumed from a recurrence, but when you're 106 years old, there are lots of different things you could die from. Well, from the middle 80s up till the present, we've operated on over 450 patients in their 80s, 22 in their 90s, and 1 patient 103. And the mortality has been 2.7%. So age itself is not a factor when considering doing a pancreaticoduodenectomy on a patient. Now, I finished my residency in 1969-70. And from that time, when I did my first Whipple, when I was a chief resident, to 2012, I did 2,000 consecutive pancreaticoduodenectomies. The median age was 67. 10% were over the age of 80, 203 patients. 7 were in their 90s, and the 1 patient was 103. Now, this was the pathology report in 1969 from that patient. You don't have to read it, but the only comment is a Whipple operation, adenocarcinoma involving and probably arising in the ampulla vata, and they mention 1 lymph node, which was negative, and they say the margins were negative. That was the whole report back then. Ralph Ruban, who is our pathologist and a distinguished pancreatic pathologist, is somewhat embarrassed about this. So the pathologists have made almost as much progress as we have. I did 1 Whipple in 1969-70 when I was chief resident. In the 70s, I was doing mostly research. I was on the faculty. I only did 2 Whipples. We started doing more in the 80s, and then the 90s and 2000s were when most of them were done. When you compare the first 1,000 to the second 1,000, the group is amazingly similar. 2/3 were for one of the periampullary cancers, the most common for adenocarcinoma of the head of the pancreas. Neuroendocrine tumors were a frequent indication. IPMN in the first 1,000 represented only 3%, increased to 8% in the second 1,000, and now our volume now represents probably about 15 to 20% of patients who undergo pancreaticoduodenectomies. When you compare the first 1,000 to the second 1,000, as you might expect, the second 1,000 were a little older. There were more patients in their 80s, and the comorbidity index increased. The 30-day mortality for these 2,000 patients was 1.4%, the hospital mortality 1.6%, and the 90-day mortality was 2%. That's 31 deaths. That's a low mortality, but when you look at the deaths, it looks like that they could have been and perhaps should have been fewer deaths. 16 patients died from sepsis. I would like to think that we should have been able to rescue some of those 16 patients. In addition, 11 patients died from bleeding, 5 from delayed bleeding. That's a difficult complication to manage. But there were 3 intraoperative deaths from bleedings. They should not occur, and then a handful of other deaths. So only 31 deaths, but I think perhaps could have been and should have been even less. When we look at the 31 patients who died compared to the remaining who survived, as you might expect, they were older, there were more patients in their 80s, and the comorbidity index was higher. Again, when we look at those patients less than 80 and those over 80, the morbidity increased in those over 80, and the mortality did also, but still, I think, in an acceptable range for that age group. The morbidity for this operation remains high, 45%, and that's really one of the challenges of the future. Delayed gastric emptying remains in our hands the most common complication, 23%. Postoperative pancreatic fistulas, 16%, wound infections, 11%. We've more recently been able to control that and lower it down to 3 or 4% by putting VAX on every patient immediately post-op. Pancreatic fistula rate remains a common complication. For pancreatic adenocarcinoma with a sclerotic gland and a big duct, it's 8%. For all other patients, 20%. Again, our fistula rate is probably higher than it should be, but it's because we put drains anterior and posterior right on the anastomosis. So that increases our fistula rate, but it decreases the incidence to develop sepsis and complications from it. Now, if you do a lot of pancreatic surgery, you have to have a good interventional radiology laboratory. 8% of our patients in the postoperative period make at least one trip to the cath lab. 5% for drainage of a percutaneous drainage of an intra-abdominal collection. Pancreatic leaks, bile duct leaks are uncommon following a Whipple, but when they occur, if you put in a percutaneous biliary drain, it automatically takes care of it immediately. And in GI bleeding, 2.4% of patients with delayed bleeding that occurs 5 or more days after surgery. So you have to have a good cath lab to support you. Otherwise, you're re-exploring patients and increasing the chance of mortality. Now, delayed bleeding has become a not frequent, but a lethal postoperative complication. It's not common. About 1.5% of patients will develop GI bleeding 5 or more days after surgery from a false aneurysm. Now, you can either take them immediately to the operating room, you can take them to the endoscopy suite and endoscope them, you can take them and get a CAT scan, or you can take them to the interventional radiology laboratory first. And we now, after doing all of the above, have decided if someone develops delayed bleeding, you take them immediately to the cath lab, have them angiogram them, and embolize the false aneurysm. The only instance in which you would do otherwise, if they're bleeding too rapidly to get them to the cath lab, then you have to operate on them. 3.5% of our patients, the 2,000 patients, required a reoperation. The most common indication for a wound problem, delayed bleeding, second, and a PJ leak, a third. 5-year survival for ampullary and duodenal in the range between 50 and 60%, for distal bile duct 35%, for adenocarcinoma of the head of the pancreas 25 to 30%. And in patients who are node negative and margin negative with adenocarcinoma of the head of the pancreas, the 5-year survival is 40%. Now, people like to do a lot of Whipples and brag about how many they do, but what is the advantage of having a high volume center? Well, one of the advantages is you can carry out prospective randomized trials in a relatively short period of time in one institution. And we've carried out 10 or 12 trials over the years, many of them led by Keith Lillimoe and Charles Yeo, with presentations at the American Surgical Association. So that's one advantage of having a high volume center. The second is it has attracted in our institution the largest group of clinician scientists and basic scientists interested in pancreatic cancer. We now have $25 million of active direct support for studying pancreatic cancer yearly, and we have an endowment of over $35 million. This has been attracted because we're a high volume center. This is a partial list of those that have participated. Notables are Ralph Ruban, a pathologist, pancreatic pathologist at Hopkins, who is the most frequently cited investigator in pancreatic cancer in the literature in the world. Bert Vogelstein, who already has done more work in working out the molecular changes driving colon cancer to perhaps someday receive a Nobel Prize. He's now turned his interest to pancreatic cancer. And Chris Wolfgang, who leads our not only clinical group, but also research group for pancreatic cancer. Now, I put this slide in 2,000 consecutive pancreaticoduodenectomies at an academic institution, a teaching hospital, to point out I did the first pancreaticoduodenectomy from the first incision to the last stitch. The next 1,999 I helped a year 4 a year 5, or a fellow do the procedure. I was there during the whole operation from beginning to end, overseeing and watching and perhaps directing, but having a trainee do the operation. You can do that. You can use this operation to train young people in a teaching hospital and still have the same good results, perhaps even better results than if you were doing them by yourself. Now, helping young individuals has resulted in training a lot of young people who have gained confidence in themselves and their ability to operate and have gone on to achieve leadership positions elsewhere. I put my name at the top because I've learned more than any of them over the years, mostly from them. In helping them do the procedure, I've learned more from them than they have from me. But Mike Zinner, Keith Lillimo, Charles Yeo, Henry Pitt, Mike Czar, Dave McFadden, Talamini, Udelsman, Selwyn Vickers, Jeff Drebin, Mike Chody, Rich Schulich, Herb Chen, Kevin Stavely O'Carroll, Herb Zay. Recently, 3 women, Julianne Sosa, Nita Ahuja, Martha Zeiger, have all achieved leadership positions after training or being on the faculty and being exposed to this high volume. There are other people like Tim Pollock who have joined our faculty, haven't trained at Hopkins, but I think have benefited by being there. So, and there are a lot more, Matt Weiss, et cetera, Gene He on the way. Now, in blue marks the pancreatectomies done laparoscopically at Hopkins, over 450. In the red are those done robotically, over 125. This program has been led by a brilliant young Chinese-American surgeon at Hopkins, Gene He. Gene He, remember that name. You're going to hear a lot more from him. There's some argument, I guess, still from our prior speaker about whether this operation should or can be done minimally invasively. To the young people in the audience, learn how to do them minimally invasively, or 10 years from now, you're not going to be doing pancreaticoduodenectomies. This operation is on the rise, and I think 10 years from now, 70 or 80% are going to be done minimally invasively. Neoadjuvant therapy using either FOLFIRINOX, Gemzar, Abraxane, or GTX. We recently reported in the Annals of Surgery, again, our group is now led by Chris Wolfgang, 200 patients treated with neoadjuvant therapy who were either borderline or locally invasive and not thought to be resectable. Some were thought to be unresectable. They were treated with neoadjuvant therapy. About 10% had a complete response, and those with a complete response had a 60% 5-year survival. I think we're now at the point where every patient should be treated with neoadjuvant therapy. Not those that are just borderline or locally invasive, but every single patient, even those that seem to be so eminently resectable without any other chemotherapy help. I think neoadjuvant therapy has been advocated by MD Anderson and Fox Chase for 20 years. I think we're finally at a point with the drugs that we have that everyone should receive neoadjuvant therapy. Immunotherapy so far has not been successful, but I think eventually it's going to be a big help. Circulating tumor cells. Chris Wolfgang, the last American Surgical, was the lead paper demonstrating that patients undergoing a Whipple for pancreatic cancer who subsequently will develop a recurrence months before it becomes evident, you can detect circulating tumor cells and perhaps treat them earlier and extend their survival. Circulating DNA, I mentioned the name before, Vogelstein. He just received a grant for $50 million, $10 million a year for the next 5 years to work out his test for detecting pancreatic cancer by detecting circulating DNA. This study is being carried out in central Pennsylvania in a stable population. So I think there's great hope that test may be allow us to detect patients with early pancreatic cancer well before it's detectable in any other fashion. Now, to end, after I did the 2,000 Whipples, I've done 400 more Whipples. The last one was 6 months ago at age 81 when I did the last one, and finally have been convinced that it's time to stop and pass the baton on to others. So I compared the most recent 400 done since the 2000 with the first 400 I did in the 80s and early 90s. And they're amazingly similar. The age, a little bit older, the number over 80, a few more, but otherwise very similar. And when you look at the results, delayed gastric emptying was almost exactly the same, pancreatic fistulas, wound infections, etc. In hospital mortality, I was shocked to see that the first 400 I did in the 80s and 90s, the mortality was the same as the last 400. So what happened to allow us, when the group of us, many in the audience, in the 80s decided to take up this operation, what was it that allowed almost immediately for us to do this operation with a markedly dropped mortality? It didn't slowly drop from the 80s to the 90s to the 2000s. It was low immediately when we, all of us, many of you in the audience, developed an interest in it. Well, one was volume. We all started doing many more. Adequate drainage of the pancreaticoduodenostomy. I can't emphasize that too much. That is important. I know there are still a few holdouts who don't think you should drain that anastomosis. The young people in the audience, don't pay any attention to that. Drain that anastomosis. In addition, I think all of us, Warshaw, Buechler, Brennan, Tanaka, everyone all over the world that started doing this operation in the 80s, we were disciples of Halsted technique promulgated in the United States in the 90s, and Coker in the early 20th century, Coker throughout Europe, of careful hemostasis, careful handling of tissues, meticulous technical feat. That's what lowered the operation, not working day by day, improving it. And all of a sudden and immediately in the 80s, the operation was improved. So in the last 4 decades that I've been involved with this operation, it's been an exciting era. A lot of improvement has occurred. For the young people in the audience, the next 4 decades are going to be even more exciting with more advances. So I look forward as an observer to watching this unfold. And I thank the audience for the privilege of giving this talk. Thank you very much.